material. So without further ado, occupational therapy and cancer rehabilitation. This is the first time we've covered this topic, so we're very excited about that. We have Farrell Wiggins MS OTRL and Alexis Petteway MS OTRL. So thank you both so much for being here today. Farrell, I understand that you have, as mentioned, MS OTRL credentials, graduated from UNC in 2011 with a degree in exercise and sports science. In 2013, graduated from East Carolina University with a master's degree in occupational therapy and became a board-certified and registered occupational therapist. And you've been practicing at UNC Health for 9 years, with 7 years being in oncology. You're a PORI certified oncology rehabilitation therapist, and you've completed courses in chemotherapy and cancer exercise management, as well as pelvic cancer and lower extremity rehabilitation. Did I get all that right?
You covered it. Thank you.
Absolutely. And can you tell me, is there something in your personal bio that you might want to share with us as well, outside of your professional one, a hobby or interest?
Sure. I'm a mom. I have a 1-year-old, and I love being outside and spending time with my daughter and my 2 dogs.
Great. Well, thank you so much for being here today. We really appreciate that. And we also have with us Alexis Petteway, MS OTRL as well, graduate of the University of North Carolina, Chapel Hill with a bachelor's degree in exercise and sports science and a master's degree in occupational therapy. Alexis, you've been working in the acute care setting at UNC Medical Center for over 4 years and consistently covered on oncology floors. Psychological Oncology Rehabilitation Institute, PORI certified therapist, having completed the foundations of breast cancer rehabilitation courses. So Alexis, welcome, and same for you. And anything you might share with us outside of your professional bio?
I am not a mom. I'm a cat mom to my wonderful cat, Edgar. But I love spending time with my friends and family, going out to eat. So any food recommendations, let me know.
Great. All right. Thank you both so much for being here today. Let's see. I mentioned poll everywhere. This is just a mock-up of our first question, but what does OT stand for? Occupational therapist, orthotic technician, occupational technician, or operation technician. So in a minute, we'll give everyone a chance to answer and see what you know. I'm pleased to say that I no longer have to read every word of this entire slide. So I'm just going to put that up there. That's our disclosures. We've done due diligence in sharing those. All right, and here's the real slide. So what does OT stand for? And we'll give our audience about 15, 20 seconds. We try to make this kind of a softball, this first question. So looking good so far. And Farrell and Alexis, how are they doing?
Great.
100%.
Yeah.
Good job.
A+.
Awesome. Awesome. Thank you. Okay, so I will stop there, occupational therapy and cancer rehabilitation, and turn it over to the two of you. And I just want to remind our audience, be thinking about your questions. You might want to jot those down, and we'll let you know when you can start sharing those in poll everywhere.
Awesome. Well, thank you so much, Tim, for that wonderful introduction. We are so happy to be here. Once again, I'm Alexis, and this is Farrell. So thank you for joining us for occupational therapy and cancer rehabilitation. We hope that you learn a lot from our presentation, and we are able to just be a source of support and a resource for you for future learning as well.
So our learning objectives, number 1, explain what OT is and our role in health. Recognize how occupational therapy can benefit the oncology population in various settings, and identify how occupational therapists measure and address physiological changes from cancer as well as cancer treatment, and how those impact occupational challenges.
So we have another poll everywhere question for you all before we get started. So we wanted to do a quick poll of the room. So in your own words, please describe what you think an occupational therapist does. And this is anonymous, so write whatever you feel is appropriate. But yeah, we'll just give everybody a second to jot down, a couple words or a sentence or two. We might already have some OTs and PTs on the line, so this should be easy. Helps people do what is meaningful to them. That's great, yeah. Assist patients to regain or maintain their ability to perform ADLs. Perfect. Nice. So some answers focusing on ADLs. Oh yeah, quality of life. And y'all are doing really good. Therapy for everyday functions. Someone who helps people participate in everyday activity, whether it's showering or cooking a meal. Assist people to learn better ways to do ADLs when sick or injured. Work on daily occupational roles and routines that support well-being and health, and support daily living. I'll give maybe like 1 more minute for those responses to keep coming in. OTs work with patients to help them be successful with ADLs. Nice. Help with your livelihood and improve physical abilities. Yeah, y'all are crushing it. Everything. Getting back to doing daily activities and the things that they love after disability, injury, or illness. Assist patients with relearning fine motor skill functionality. Help patients regain independence with their ADLs, and to address activities of daily living. Awesome. Yeah, y'all are doing great. So lots of like daily living ADLs, which is you're hitting it right on the head. That's perfect. Nice. Help patients with physical issues like mobility and daily activities. Holistic approach. I like that one. I'll look up 1 more. Help patients with disabilities perform daily functions and ADLs. Nice. And energy conservation. Perfect. Well, thank you so much for those responses. Those were actually really great.
Yeah, I feel like this crowd already has a good grasp of what it is that OTs do. I do want to address, though, some common misconceptions about what is the role of occupational therapy. I will say about once a month when I walk into a patient's room to introduce myself as an occupational therapist, the response I get is, I'm retired, or I already have a job. And that's okay. I do a lot of education with the patient to explain I am not here to help you find employment, but this is what I do. Other common misconceptions that we hear a lot is that OT primarily just works with hands and upper body. That is a specialty in OT. We get people jobs. We address all forms of doing. We are part of physical therapists. We do collaborate a lot with PT, especially in the hospital. We are not paid or covered by insurance. We are covered by many insurance types. We are in school systems, and that we can only be consulted once there's a functional decline. However, we can play a big role in prehab and in prevention. I think occupational therapy is difficult to understand sometimes because people's lives are so different, and occupations mean many different things to different people. So we hope this presentation gives you a more thorough understanding of our role and what it is occupational therapist does.
Awesome. So in order to grasp truly what OTs do, we first want to explain what is this notion of occupation, right? So when you think of occupations, we want you to think of roles, habits, and routines and all of the activities that comprise those. So personally, think about all of the activities that comprise your routine, like starting from waking up in the morning. Those are going to be your occupations. So occupations happen from birth to end of life. So occupational therapists work with people across the life course, which is very exciting because you could work in the NICU or you could work in hospice. So the field is very vast. Occupations are super complex. So there are emotional aspects of it, like the meaning, identity, motivation, and social connections. There's cognitive aspects of occupations such as attention, planning, decision-making, and problem solving. There's also the physical aspects, which is probably most familiar to people. So the motor, the sensory aspects. And then there's that interaction between the physical and social environments. So I really want to hone in what Farrell was saying before, because occupations sometimes are difficult to conceptualize and describe, because they just vary based on the person, their environment, their culture, and their preferences. So how I engage in a specific occupation might look very different than how Farrell is going to engage in that same occupation. So it can be very hard to understand what is an occupation, but hopefully as we go through this presentation, and if you maybe have experience working with occupational therapy, it becomes more clear. Okay, and so this occupation, this notion of occupation is going to be very essential to health and well-being. So the essence of occupations live in this idea of doing, being, becoming, and belonging. So if you imagine not being able to do what you want and need to do, or not being who you identify as, not being the person that you want to be, and not belonging in the group that you want to belong in, how detrimental would that be on your life? Oftentimes, occupations are the things that we do or we don't think about until we're not able to do them, which can be, very jarring for people. I know a lot of patients that we work with, they start having difficulty with some of the basic occupations that they're typically able to do. And they're like, I never even thought about having to do this before. So it can be a very big transition. It shakes people's roles up, definitely.
So occupation is the core of our profession. It is what occupational therapy comprises. We use occupation as an intervention, and we also use it as outcomes for health and for well-being. So Alexis and I, we both work in the hospital setting. We work primarily in what we call acute care environment on the oncology floors. So the occupations that we work on a day-to-day basis, most patients are ADLs. Some IADLs rest and sleep. We look a lot at their motor skills, their process skills, and the environment that they're currently in is in the hospital, but we want to find out more about their home environment and their environment they're returning to. Occupational therapy is currently, for education, is an entry-level master's and or doctorate program. My OT program was 2.5 years, and then we did clinicals for 6 months or more. And so this table that we're looking at is from our occupational therapy practice framework, and it identifies aspects of the OT domain. As OTs, we are trained in evaluating all aspects of this domain, and we really look at how they're interrelated.
So we wanted to break down these two specific occupations, ADLs and IADLs, because that's what we typically work with in the acute care setting. This is from our American Occupational Therapy Association, that same practice framework that Farrell was talking about. So a lot of this verbiage that you see on the table is something that you might see an occupational therapist use a lot in our documentation and how we might describe patient interactions. Activities of daily living are what you think pretty much when you hear self-care. Instrumental activities of daily living typically comprise of those higher level or more complex tasks. So like an example of that would be like driving and community mobility, taking care of the home, money management, health management, some of those higher level, maybe out of the home tasks as well. These are not the only occupations. So there are also rest and sleep, education, work, play, which is typically more in pediatrics, leisure, and social participation. So these terms are not only for OTs. As you'll often see ADLs and IADLs in other medical jargon or other medical documents, a lot of other medical professionals also use these terms, but it is how we as OTs conceptualize and organize and also describe this idea of doing.
So what's the evidence for occupational therapy? This is by no means an exhaustive list, but these are studies that have been done within the last 5 years that show the benefits of OT across various settings. So here we have an inpatient hospital setting, outpatient, home health, pediatrics. I'm not going to talk about all of them, but I do want to discuss our role in reducing hospital readmissions. As is known that adults with cancer are at high risk for functional decline, which can in turn lead to increased hospitalizations. So the article, the study done by Rogers et al. In 2017 found that occupational therapy is the only spending category where additional spending has a statistically significant association with lower readmission rates. And in that study, the 3 health conditions that were studied were heart failure, pneumonia, and acute myocardial infarction. So it also suggested that OT does this because we place an immediate focus on the patient's social as well as the functional needs. So I thought that was a really great article and really kind of helps validate our profession. So what do we do? This is the process. This process is pretty similar in the various settings that we work. The assessment used and the interventions created, however, will be tailored to the specific patients. Our goal during this process is to understand who the patient is and what is important to them. We start with a chart review. So this chart review would look different in a school setting than it would in a hospital. But we usually will, at least in the hospital, we look at all the notes. We check the orders. We have to have an order before we go in and see the patient. We really look at the lab values, especially in oncology, so that we know if a patient has low platelets or low hemoglobin, how that might affect their energy levels. Look at imaging. What are they hooked up to? Lines and leads. And then the occupational profile. So it's a summary of a client's occupational history and experiences, their patterns of daily living, their interests, values, needs, and relevant context. This is my favorite part of working with the patient and a part of the process. I get to spend time with patients and I get to know them. Usually when I walk into a room, as best as I can, and if the opportunity presents itself, I try to pull up a chair, sit on a couch, or get on a patient's level as we go over, and I ask them questions and make it more of a conversation than just a checklist that I'm trying to check off for them. So I want to understand who the patient is and what is important to them. Questions that we might ask to find this out. What does your home environment look like? Who are your support systems? What do you enjoy doing? Who are the key people in your life? Who helps you when you need it? Do you live with anyone? Can you describe your home? And depending on the setting, you might go deeper into certain questions. So we go into the assessment part. Assessments used typically will vary depending on the patient population and in the setting, but they can be patient-reported outcome measures, standardized functional assessments. In the hospital, it's a lot of ADL assessments, manual muscle testing, range of motion, fine motor, sensation, vision, so many things, cognition. And then the goals. So goals are created in collaboration with the patient and with the caregiver. They're not made for the patient. And then what do? We identify the impairments and we intervene. I won't go over all the interventions right now because we will have specific case examples later, but these are just some different ideas of intervention.
Okay, so let's delve back into what the research says specifically about occupational therapy in individuals with cancer. So in this study by Neo et al., it provides just a generalized review about the literature on how daily activities are impacted by cancer. So 1/3 of adults with cancer have difficulty performing ADLs. 1/2 of adults with cancer require assistance performing ADLs. That's a huge number of people with cancer. And that's, that amount of people is the amount of people that could be getting occupational therapy too. So that's a wide range. In this study, though, it included 43 other studies comprising of 19,246 patients. And so overall, there was 36.7% and 54.6% of patients, respectively, reporting disability related to basic and instrumental ADLs. So typically what we see, especially in the acute care setting, is IADLs are one of the first things to go. So usually like somebody's cleaning, meal prep, their ability to access the community, to drive, those are one of the first things we see to start to dwindle a bit or for people to need assistance with. And then kind of once the course gets going, then people might start having difficulties with their ADLs. But it can be subtle because at times, people are very independent with their ADLs and just have a slight, decrease in participation in IADLs, but that can be kind of an indicator for us that they're getting a little bit more deconditioned. So overall, the findings of this study just underscore the importance of professionals that are going to be skilled in occupational assessment and therapy in cancer care, as there needs to be somebody on the medical team that is going to be able to identify these impairments, intervene on them in a performance-based manner.
And we'll go through a few more studies. This one was done in Denmark. And had 164 participants were recruited from outpatient oncology units. The assessment of motor and process skill, which we call the AMPS, was used as the observed ADL assessment. And in that assessment, the patient performs at least 2 ADLs of their choosing, and the results are graded. The ADL interview that was used was just a self-reported ADL interview. And it was reported on 47 tasks related to ADL as well as IADL. What was found was observed high ADL motor ability had a statistically significant association with higher quality of life among people with advanced cancer. And the findings indicated that observed ADL had a stronger association with quality of life than self-reported ADL. A couple more articles, both are from the Australian Journal of Occupational Therapy. The first one was published in 2021 by Taylor et al. And it discussed how advances in cancer have obviously led to increased survival rates and survivorship. And the findings indicate that OT programs that are patient-specific, monitored, and compensate for fluctuation in a patient's conditions have efficacy to improve patient outcomes at discharge. The other one, also from the Australian Occupational Therapy Journal, was published in 2020, and it was data from 181 patients. And the results support the value of OT to cancer rehab and highlights the positive impact of occupational therapy on everyday function.
So honing in on this notion of quality of life, we want to highlight this study by Farrell et al. That really shows that adults with cancer are at increased risk of decreased functional status and decreased quality of life. So there are side effects of cancer itself, but also treatment-related effects that are going to contribute to this decrease. And it puts adults with cancer at a higher risk for mortality, institutionalization, and long-term disability. So in the table on the far right corner of your screen, it shows how cancer and its related treatments can impact body processes and functions. And this contributes to that decreased occupational performance and overall decreased quality of life. Occupational therapy is going to utilize a variety of tools and techniques to improve the functional capacity, such as these weaknesses, peripheral neuropathy management, fatigue management. And although occupational therapy can play a unique role in supporting those with cancer, thus improving quality of life, it is often an underutilized service. So that's one of the main takeaways from this article is it's a resource out there that's underutilized, but it's something that can help support quality of life for our people with cancer.
So Alexis started to touch on cancer-related impairments. Obviously, these impairments can come from not only the disease process, but also the effects of treatment. So the effects of chemo, the effects of radiation, the effects of surgery. So the table that's on the left shows a list of common cancers, especially that we see at the medical center, and occupational problems related to those cancers and cancer treatment. And as OTs, we can assess the impairments, we can measure the severity and the impact, and then we couple the intervention with the impairment. As you see on the table on the left, there are some impairments that are cancer specific, but a lot of them overlap. So we would probably be here the rest of the afternoon if I went through all the interventions that are listed, so I will only highlight a few. The first one I want to talk about is cancer-related fatigue. Fatigue is probably the biggest impairment that most of my patients face. I will have patients tell me, I used to be able to do this, haven't done this in a long time. Every day I can do a little bit and then I hit a wall. I've also found that fatigue with patients leads to isolation. I feel so alone. I don't have the energy to do anything. What do we do for fatigue? We can educate the patient on why they are so fatigued. It can be effective your chemo. Your routines are disturbed. You're in and out of the hospital often. You're not getting great sleep. The disease process. We also educate on sleep hygiene, how to act, how to get better sleep, different strategies, different routines you can incorporate. Exercise is huge for increasing your fatigue and your energy levels. Pilates, yoga, Tai Chi, and then energy conservation. So teaching them how to prioritize, how to plan, how to pace, how to position. Another impairment, cancer-related cognitive impairment. We educate the patient on what could be causing this. It can be effects of chemo, fatigue levels, they're out of your normal routine. We find that planning, sequencing, the ability to learn new things, and word finding are common issues that we see with cognitive impairments. And how do we intervene? We teach the patient how to modify the task, how to modify their environment. We educate the patient and the caregiver. We teach them compensatory strategies. We try not to provide too much education. We kind of find that one important message each time really helps the patient carry that over. One more that I'll talk about is pain. So as an occupational therapist, we do not administer medication. So I cannot completely cure a patient's pain. And it's important when I'm discussing pain with patients to be honest and to be realistic about this. I cannot completely cure, I cannot fix your pain, but I can intervene. I can help with task adaptation, with positioning, maybe brainstorm some durable medical equipment or assistive devices. Guided imagery. There's so many different techniques that we can use to help with pain.
So now that Farrell has talked about some of the interventions for occupational therapy, we want to provide some evidence about those interventions. Now, these two studies are going to be systematic reviews of occupational therapy and the interventions that help, and specifically in oncology. So cancer rehabilitation can benefit people with cancer from diagnosis to end of life. The role of occupational therapy practitioners is going to be well suited to help cancer survivors at all stages of their illness. There's strong evidence that exercise is safe and beneficial for the majority of cancer types at all stages, including end of life and regardless of age. Of note, exercise was not found to make lymphedema worse. So we often incorporate exercise a lot into our interventions. It's not solely what we do, but the main thing is, how do people incorporate these exercise routines or these activities into their daily routines? That's a lot of what we do as well. Like, is it going to be realistic for you to do a home exercise program 3 times a day at your typical routine? There's also evidence for non-pharmacological interventions, such as like problem solving, energy conservation, education, and other education, to reduce the symptoms of breathlessness, which is something we often see as well. Strong evidence that there is psychosocial strategies like cognitive behavioral and educational interventions about problem solving, knowledge of the illness and side effects. And this evidence showed that it helps to reduce anxiety up to 3 months post-treatment and depression 1 to 3 months post-treatment. So I think that's huge. And that's a lot of what we do, as well as those psychosocial interventions. It's not just physical and exercise. Now, moderate evidence was found to support sleep therapy modifications in educations. So like problem solving for pain management, and that cognitive behavioral therapy for cancer-related fatigue. And then we can also touch on intimacy. So the systematic review pointed to 3 types of interventions for a return to sexual function, and that was exercise, medical, and psychoeducational. So the main takeaway from these reviews is the vast nature of occupational therapy and what we can intervene on. It's not just the physical, it's not just the psychosocial, and it's not just, the cognitive. It's all of the above. And we can often take a very holistic view and intervene on a bunch of different things all at one time, depending on what the person needs and what they want. Okay. So we also want to talk about this article here. So this is going to be a feasibility study, and it provides evidence for an in-home activities program that allowed individuals increased opportunities for engagement in their preferred activities and increased confidence in those preferred activities. So this study took more of a top-down approach, which is going to place activity engagement directly to target disability versus an impairment-focused approach. So you're taking the activity as a whole to engage versus just saying, oh, somebody's tired, we're going to address that. Somebody has pain, we're going to address that. And so this conceptually can be very appealing in oncology. And especially with cancer survivors, they often have little energy for access to rehabilitation and community-based rehabilitation programs. So providing an activity that's going to be in-home in their own environment is going to be very useful. And it's something that could be an ideal option. We wanted to provide evidence for, OT outside of the hospital setting, to say like even community-based and home-based occupational therapy programs are going to be very essential for establishing and helping that quality of life and that overall activity engagement. So I don't know how many people have seen this, but this is going to be from the World Health Organization. It's the International Classification of Function, Disability, and Health. And so it provides an excellent way for us to conceptualize how we fit into the overall health processes, as well as how we interact with the broader health system and health team. So occupational therapy is going to come in on that sweet spot between activity and participation, that transaction between activity and participation. However, I want to note that everything in this broader system is going to connect. So in order for us to look at the activity, we also have to account for the body structures and functions, the health conditions, the environmental factors, the personal factors, and the participation. And we have a couple of other healthcare providers up here, like MD, RN, and physical therapy. But I don't want you to, this is not the only people that are interacting in our healthcare system. So there's also speech therapists, there's dietitians that are on the team, there are nurse practitioners, physician assistants, and they all interact and come in a certain way so we can provide a more holistic view and interdisciplinary focus to the patient.
All right, so back to a poll everywhere question. If you or a loved one was faced with cancer, what would be the occupations that you would be most concerned about? So if you'll just kind of pop in like a one-word answer, and I think a word cloud will be created out of these. I'll give you a minute or two. Yeah, these are great. Leisure, independence, dignity with toileting, fatigue, eating, driving, being outside. I think the words that get bigger are the ones that have multiple answers. So I see self-care and fatigue. We'll give it a couple and 20 more seconds. Those are all great responses. There are things that patients talk to us frequently about being concerned about being able to do. And I like to think they're the main things that we focus on with patients. Helping a patient become as independent as possible is the nature of our job. It is what we're there to help with. And lots of those things are with toileting, or with eating, or with bathing, taking care of themselves and maintaining their dignity while doing that. So good responses, everyone. All right, go next one. All right, so we've talked a lot about what it is we do, why we do it, how we do it. And so we're going to start with 2 case studies. that hopefully will tie everything together. The first one Alexis will cover, and it is a young adult teenager inpatient case study, and the second one is an outpatient focus study. So I will let Alexis take over.
Okay, so here's our first case study. You can read it. I'm gonna read it out loud for those who might not have video access. Okay, so AC is a 19-year-old male with left femur osteosarcoma diagnosed in 2021. Unfortunately, it has already metastasized to brain, lung, and spine. He presents to the hospital with uncontrolled pain and new lower extremity weakness. His current cancer treatment includes chemotherapy and daily radiation to his left femur mass. He was evaluated by orthopedics, and they recommended left lower extremity non-weight bearing and a knee extension brace. His primary medical team places a consult order for occupational therapy for ADL and discharge recommendations. So here is that process that Farrell was talking about. We want to kind of take you through how we as occupational therapists would reason through and work with this patient, AC. So there is our occupational profile, our favorite part, just getting to know who is AC as a person holistically. So he is fiercely independent at baseline. And, you know, prior to his diagnosis, he was going to attend college. And so his idea of being an athlete has followed him throughout his life. And so since diagnosis, since he's having to move back to North Carolina, in our heads, we're thinking how much has his role in that idea or that identity of himself changed now that he is not in college, now that he is not able to play sports. He lives with his father, but they have a strained relationship. So in terms of ADL and IADL performance, we're thinking that maybe he would need to be fairly independent with completing those. He might not be able to have support from his father with that. Especially because his other family is out of state. He enjoys playing video games and spending time with friends. So that's what's important to him. So Farrell kind of hit on what our acute care assessment is going to look like. And we're interacting with AC in an acute care basis. So we're going to test his upper extremity, lower extremity range of motion, manual muscle testing. A lot of that is going to be within functional limits. So we're not necessarily getting like measuring tape out and a goniometer, but like, can you raise your arm up to get your shirt on? Can you bend your hip to sit down on a toilet? Those types of things. And we're doing it in the context of his left lower extremity non-weight bearing precaution as well. We also want to get people up and have them do things. So we get them to the edge of the bed. If we can, we get them out of the bed, try and take them to the sink, see if they can do a standing grooming task, see if they can get some shorts on or some, a t-shirt on, those types of functional tasks, just to see whatever they can do. Some people can do it all. And some people on the day we see them are having a lot of pain and they can only maybe sit up at the edge of the bed, and that's fine. We also did a modified version of the COPM, which is the Canadian Occupational Therapy measure, performance measure, I'm sorry. And so what this does is it kind of rates people's activities, daily activities, and it has them rated on a scale of how much how important that activity is to them, and how satisfied are they with doing that activity. So in that way, we can see, okay, playing video games is important, but it's not as important as like maybe getting himself dressed in the morning or something like that. We also did a number of other things, the FACT, emotional well-being, to kind of highlight a little bit about his mood. The MOCA is a cognitive assessment just to see, especially if there's brain mets, we want to see any type of cognitive changes. And the impact self-care is what we do. It's just a generalized measure that can be done. We can rate it, or we can have somebody perform those tasks like getting on and off a toilet, putting clothes on, those types of things. So the occupational problems that emerged from his assessment were lower body dressing, specifically related to the pain from his lower extremities and back, toileting, and functional mobility and social participation. And a lot of that social participation emerged because he wasn't able to complete his self-care. So he didn't feel comfortable leaving his home. So kind of delving into those occupational problems. Here are some of the goals that we did for AC. These are typical goals you might see in acute care from an occupational therapist. They are typically really ADL focused, some IADLs, but it's kind of hard to do a lot of IADLs in the hospital setting. So that's why I think we focus a lot on ADLs, and it's what he was having difficulty with. So how did we intervene with AC? So we worked a lot on standing ADL tasks. Because he was non-weight bearing in his left lower extremity, that means his balance had to be really good, his endurance had to be really good, and his pain had to be controlled in order to even just stand at the sink and brush his teeth. Lower body dressing was going to be difficult because he wasn't able to bend that left knee in the brace. And when he stood, he was only able to stand fully on that right leg. So we introduced like adaptive lower body dressing equipment, like a reacher and a socket to kind of help him. And it helped him maintain his independence without having to ask his father for support in the home. A lot of our interventions in acute care are very education based as well, because we don't want to overwhelm the patient, but we want to give them as much information as we can, because we don't have a confirmed number of visits with them. We might see them one time, we might see them 10 times. It just depends on their medical and hospital course. So we want to give them as many of the tools and resources as we can while we see them.
All right, so Alexis did a good job covering the inpatient case study. We will switch gears and look at a patient who was in the outpatient setting. Miss L is a 38-year-old female diagnosed with breast cancer. She's had chemo, she's had a mastectomy, she's had surgery. She was hospitalized because she became COVID positive and required a 2-week-long hospitalization. While hospitalized, she experienced acute altered mental status, and a brain MRI was performed. It was learned that her cancer has now unfortunately metastasized to her brain. Her mental status has improved, but not completely returned to normal. So while she was inpatient, she was seen by occupational therapy, and outpatient therapy services were recommended. So we will go through the same process, and we'll be cognizant of time, so I will kind of go through this one a little bit quickly. So Miss L, she presents to you for an outpatient OT evaluation. She's actually independent with her ADLs, but she does demonstrate proprioceptive deficits, fatigue, executive functioning challenges, including decreased sequencing, impaired attention, and decreased short-term memory. She has noticed increased difficulties with maintaining productivity at work and feels that she is not fully able to fill her role as a new mother. So when we met Miss L, we learned a lot about her. She is a social worker. She works in the hospital. She and her wife have recently adopted an 8-month-old. So she is very busy. She completes most of her IDLs for the house. That's kind of her role that she takes on. She does the grocery shopping, the driving, most of the cleaning. Her wife does most of the cooking. And her main enjoyment comes from spending time with her son and reading. And her role as a mom is the most important role to her. So some of the similar assessments that were done in the inpatient setting can be done in the outpatient setting as well. We added on a couple, one to really look at her fatigue and her cognition. And then what did she identify? So through the COPM, her main things that she wanted to work on, childcare, being able to take care of her 8-month-old, returning to work, that she got enjoyment out of her job and she wanted to go back to it. And then yoga for relaxation, for exercise. So she was seen 1 time a week for 4 sessions. And then after she returned to work, there was 1 follow-up session. Here are her goals, most of the occupational problems we covered, and then intervention. So what did we do with Miss L? Lots of education for the patient as well as for her wife, sleep hygiene, memory strategies. We created some memory aids. We really talked a lot about her routines and specifically trying to change up her bedtime routine so that she was able to get her child down like 45. We tried 30 to 45 minutes earlier and get herself to sleep 30 to 45 minutes earlier to see if that kind of helped with her overall energy levels. we looked extensively at fatigue management strategies. We talked about how yoga can help with that. We discussed how to incorporate more walking and exercise into her day. And then we also looked at education on information processing, specifically when she returned to work. So developing strategies related to her calendar, alarm on her cell phone, and then other technology that could help with that. So I know we ran through those quickly, but hopefully that how it's laid out in this process can help you get a good idea of these case studies. So one more thing we want to touch on is that we also work with patients in end of life. So we follow individuals throughout their life course. The role of OT in this stage is to introduce compensatory strategies to help the patient engage in things that are meaningful to them and mitigate symptoms. When I see a patient that is going home in hospice or is towards the end of life, I acknowledge the gravity of the situation, but I still want to help them and their family problem solve how they can participate in things that are meaningful to them, hopefully help mitigate some symptoms. We do a lot of family training, whether that's helping recommend certain durable medical equipment, hospital bed, 3-in-1 commode, a Hoyer lift, teach the family how to use it. Just kind of help the patient do the things they want to do when they get home and also keep the family safe and helping the patient. Just sharing some quotes that patients have said to me. The one that really hits home, I want to maintain as much dignity as possible. Getting to the bathroom by myself is very important to me. I want to be able to safely hold my first grandchild. So I want to make sure it's known that occupational therapy is a service that's covered under hospice. Barriers to this, it's not commonly seen in the setting, but barriers because home health and hospice agencies that are not in compliance and lack of knowledge in referring professionals. And we will end with one more quick question. So how do we access OT? This is probably a big one. We need a referral. So a referral from a physician assistant, nurse practitioner. And then what settings are we in? I know we talked a lot about the settings, but we are in acute care. Typical, we see patients 3 to 4 times a week, anywhere from 15 minutes to an hour. I'm in the room with a patient. That will look different based on what setting you're in. So inpatient rehab, LTAC, long-term acute care hospital. General subacute rehab is skilled nursing facility. Home health therapy and outpatient therapy. And this kind of chart by Pergolotti et al. Kind of gives a good explanation of the amount of therapy received in all of these settings.
And we want to end, there's ongoing research, and the field of occupational therapy needs lots of research to kind of help continue to support and validate what we do. But Farrell and I currently have the opportunity to participate on Dr. Ashley Bryant's study, and it's about a palliative care model and interdisciplinary team with nursing, PT, and OT. And so we get to work with older adults with leukemia and really develop a protocol, intervene on that protocol, and really build just very valuable relationships with individuals and their care partners. So we definitely want to give a shout out to Dr. Bryant. Thank you so much for allowing us to be part of the study and for helping us to continue to advocate for occupational therapy. We also work with our kind of mentors and consultants, Dr. Sue Coppola and Dr. Mackenzie Pergolotti. And so they have been such a valuable research, and they have given so much to the field of occupational therapy. So we didn't want to end this without acknowledging their contributions as well. So look out for the PAC study. It's coming.
So I know we kind of flew through some of the end because we're running out of time, but last question. Should be easy one, I hope. What is the role of an occupational therapist? And it's a multiple choice answer. All right, looks like Most people got it.
Yeah, any answer you choose is right.
There's no wrong answer
Yes.
for this one. References. So now we're open up to questions.
Terrific. And so, Farrell and Alexis, thank you both so much. This has been extremely informative. I want to remind folks you can go ahead and use Poll Everywhere now to submit your questions, and then we'll post those as soon as we start receiving them. I wanted to make a quick mention, and then I had at least one question while we're waiting for others to roll in. You mentioned so many things that made me think of previous lectures that we've had that may be of interest to some of our audience. With peripheral neuropathy, Dr. Lopresti talking about peripheral neuropathy and prevention, talking about chemobrain. Zev Nakamura was here a while back and will actually be back in 2023 to talk about cognitive impairment. I saw Dr. Muss's name flash up on a study, and that made me think for anyone who missed the geriatric oncology symposium last week, we'll be posting all of the videos from that. I think there are 20 some from different presenters. That was excellent, and those will be up on Friday in our video library. And then Dr. Leek Bryant, you mentioned, and she's one of our favorite collaborators, and we have lectures available with her as well. So thank you for mentioning all of those. I was curious about timing. I think about the time when one receives a cancer diagnosis leading up to treatment, sometimes neoadjuvant therapy that prior to surgery, and then during treatment when one's receiving chemotherapy or having surgery or receiving radiation, and then after. And I was curious in terms of the timing. Is most of the work that each of you does as an OT in that post-treatment phase? Is there any work that you're doing during treatment? And is there any work that you're doing prior to post-diagnosis, but prior to any treatment?
That's a great question, Tim. Currently, I would say most of our work is done during treatment and in that post-surgical phase. We are trying to expand and look into what we call prehab, so some opportunities that are maybe done before a patient goes for maybe a stem cell transplant or before they go for a major surgery, and kind of educating on the front end some things that might help them through that.
Great, thank you so much. And I'm going to start making these questions available. We've already had several of them, so I'll post them one at a time, and we'll see how many we can get to. Can you talk a little bit more about how OT addresses social participation and psychosocial issues? Great question.
Yes, that is a great question. And that actually comes up a lot too, especially in oncology, because it's such a major shift in people's roles. And it can be, a lot of news that kind of affects mental health. So we do address things in terms of like emotional regulation, education on strategies, especially regarding like coping strategies. So if people are feeling distressed or anxious, how do they incorporate those coping strategies that we talk about, or those relaxation strategies, into their typical routine? We can do things like guided imagery for like in the moment relaxation. There are other OTs also who run what's called groups, mental health groups. So you come together and you talk about like occupational balance and time management, or you talk about emotional regulation and coping strategies, just so, people in the group can kind of bounce ideas off of each other in just a guided way that facilitates learning and sharing that experience. And then, some of those other strategies from like cognitive behavioral therapy about just education regarding mental health disorders and, mental health symptoms and how that impacts people's lives and routines and roles can be very beneficial.
Great, thank you. And here's another one. Have you seen an increase in the focus on prehabilitation for oncology patients? If so, how does that differ, if at all?
Another great question. Currently, how at UNC, we do not have a focus, at least with OT, on prehab. A lot of the education that we learned and the courses that we attended to become a cancer rehab specialist focused a lot on prehab. So I know it is being done at in other settings, and we hope to expand on that here. But yes, I have, at least in those courses, we did see a really big focus on prehab.
Great. Thank you for that question. How do you balance motivating a client to participate in therapy without being insensitive to their fatigue? Interesting.
Yeah, that's great.
Yeah.
I think
Everyday
the
challenge.
first step is to acknowledge the fatigue.
Mhm.
And also acknowledge that I will never know what this fatigue feels like, and not try to understand that I do. But then lots of what we do is based on our rapport that we've built with these patients. So we get to know them well. We know the things that motivate them. So whether it's, for the case study that Alexis talked about, this patient was tired all the time, but he loved basketball. So how can we do something that could help him engage in that activity? We made a makeshift basketball goal and helped him work on things that were fun and motivating to him. So a big part of that is just acknowledging, not trying to say that they aren't fatigued, acknowledge that and acknowledge that we don't know what that feels like. And then try to find what motivates them.
I think OTs are very specialized in finding what we call as the just right challenge. And so finding that sweet spot between something that's going to be challenging, but not too challenging where the person feels like they're going to fail. So really modifying that activity. So okay, if we're too fatigued to maybe get to the bathroom to do grooming, let's maybe try and sit at the edge of the bed and do it. So they're still able to engage and participate in that without us contributing to their fatigue. Because we don't want to go and preach energy conservation and fatigue management all the time and then go in and make somebody get up. So I think that rapport and finding the just right challenge for them is very important and something that OTs are very skilled in doing.
Great answer. And if one is interested in finding out more about exercise and cancer treatment, we have lectures from Dr. Wood and Dr. Bottaglini and others that I also encourage our audience to check out. Now, here's one I know part of the answer because I used to be a school teacher, and I've loved when I taught in a classroom. I loved having OTs that would come in and work with the students, and it made a phenomenal difference in their lives. What about with children with cancer?
Yeah. Alexis and I, that is not our specialty. So there are other OTs that could speak to this a lot better than we will do, but we'll give it a shot. I know at least at UNC, there's a great pediatric program and OTs and pediatrics to address oncology, cancer within the hospital. And because occupational therapists are frequently in schools, kind of like you said, I hope that there is, and I'm pretty sure that, there are OTs that kind of help with cancer in schools. I definitely know they help with other conditions in schools. So
great. Thank you. Great question now about do you train caregivers and help them to cope, the patient caregivers?
Yes, we definitely do. We do a lot of what we call family training, especially here in the hospital. So, that comes in often. And so we tend to really emphasize respite for caregivers and not getting burnt out because it's a shift for the patient, but it's also a shift for the caregiver as well. So safe transfer strategies, having, other sources of support so the caregiver can go out and run errands and get respite at times. We don't necessarily do any caregiver groups or anything like that. I know recreational therapy does do that, or they did do it before COVID. But that is a possibility. I think we talk a lot about it in the moment because we are, working with people in very, I feel intimate moments of, teaching somebody how to care for their loved one when they get home.
Thank you. And we're going to take this last question, and I apologize we didn't get to all of them, but we are going over time. So is there data comparing when in the care process, earlier versus later, is most beneficial for the OT to get started to improve patient outcomes?
There is. I will not be able to recall the specific studies off the top of my head, but the earlier the better. The earlier we're involved, the earlier we can kind of help mitigate some of the later effects of treatment.
Yeah.
Great, thank you. And thank you so much to our audience for all of those great questions. I'm sorry we didn't have time to get to all of them. I need to make a few closing remarks. I want to say thank you to Veneranda Obore, John Powell, Oliver Marth, Andrew Dodgson, Nadja Brown, and Pat Muscarella for all of their hard work leading up to these lectures and beyond. I want to say thank you to the people of North Carolina for their generous funding of the University Cancer Research Fund and their role in funding the UNC Lineberger Comprehensive Cancer Center.